Hello there. So now we'll start with gastroenterology, and like always, we'll go topic wise topic, and yes, topic wise, we'll be completing the whole subject. So let's start. Let's start with it. So, in the first scenario, there is a 55-year-old man who develops fatigue and palpitations. He had a gastrectomy few years ago. Recent blood tests were ordered which shows hemoglobin that is 98, mean cell volume that is 110. On neurological examination, there is loss of proprioception and vibration sense which were noted. So they are asking about the most likely diagnosis in this case. So here we have to study about vitamin B12 deficiency. So this would be our topic. So vitamin B12 is found in meat, fish, and dairy products. But not in plants. So, vitamin B12 is found in meat, fish, dairy products, but not in plants. Vitamin B12 binds to intrinsic factor in the stomach, and this complex is absorbed in the terminal ileum. B12 binds to intrinsic factor in the stomach, and then this complex is absorbed in the terminal ileum. Now, clinical presentation. Now, in clinical presentation, symptoms in vitamin B12 deficiency are those of chronic anemia. That is, there is fatigue, there is dyspnea on effort. Certain neurological symptoms may also be present, such as peripheral paresthesia, disturbances of position, vibration sense, and if it is uncorrected, the patient may also develop subacute combined degeneration of spinal cord leading to permanent ataxia. So, symptoms are those of chronic anemia. that is fatigue, dyspnea on effort. Second, neurological symptoms may also be present. Classically, peripheral paresthesia, peripheral paresthesia and disturbances of position and vibration sense. Now, if this deficiency is uncorrected, the deficiency is not corrected, then the patient may develop subacute combined degeneration of the spinal cord, leading to permanent ataxia. So these are the symptoms here. Clinical presentation. That is, the symptoms which are present are those of chronic anemia. That is, fatigue can be there, dyspnea on exertion can be there. Neurological symptoms can also be present, such as peripheral paresthesia is present, and disturbance of vibration sense and position sense. Disturbance of position and vibration sense and peripheral paresthesia. These are the neurological symptoms which are present. And if the deficiency is incorrected, then the patient may also develop subacute combined degeneration of spinal cord leading to permanent ataxia. Now, coming to causes. Now, coming to causes of B12 deficiency. First is pernicious anemia. It is the commonest cause. Now, causes of B12 deficiency. First is pernicious anemia, which is the commonest cause, and due to autoimmune gastric atrophy, resulting in loss of intrinsic factor production required for absorption of B12. So, due to autoimmune gastric atrophy, there is loss of intrinsic factor which is required for absorption of B12. That's why pernicious anemia causes B12 deficiency. and it is usually associated with other autoimmune problems such as hypothyroidism. Second cause is dietary habits, for example, in vegans, because as we read, vitamin B12 is basically found in meat, fish, and dairy products, but not in plants. And the third is following total gastrectomy, because body stores can last a few years, and gastrectomy would only cause depletion of the cobalamin stores after 1 to 2 years after surgery. So following total gastrectomy also. Then ileal disease, because we studied vitamin B12 binds to the Castle intrinsic factor in the stomach. B12 binds to the Castle intrinsic factor in the stomach, and this complex is then absorbed in the terminal ileum. Castle intrinsic factor helps in the absorption of vitamin B12, but not in stomach. It binds in the stomach, but this complex is absorbed in the terminal ileum. So any ileal disease such as resection of ileum or Crohn's disease can lead to deficiency. Last, malabsorption disorders such as celiac disease and tropical sprue. These malabsorption disorders such as celiac disease and tropical sprue can also lead to vitamin B12 deficiency. So first, pernicious anemia, commonest cause due to so, first cause pernicious anemia, which is the commonest cause due to autoimmune gastric atrophy, resulting in or causing loss of intrinsic factor required for absorption of B12. And third, it is usually associated with other autoimmune problems, for example, hypothyroidism. Now, dietary habits. Example, vegans. Third, following total gastrectomy. Now, because body stores can last a few years, gastrectomy causes depletion of cobalamin stores. It causes gastrectomy will cause uh, depletion of cobalamin stores after 1 to 2 years. post surgery. Fourth cause is ileal disease. Any ileal disease, because it is absorbed in the terminal ileum. So any ileal disease such as resection of ileum and Crohn's disease, they will also cause vitamin B12 deficiency. Fifth cause is malabsorption disorders such as celiac disease and tropical sprue. So these are the malabsorption disorders. So these are the causes of vitamin B12 deficiency. Now let's move on to the hematological abnormalities of vitamin B12 deficiency. Hematological abnormalities of B12 deficiency are, uh, first let's go through the causes. Once causes are pernicious anemia, which is the commonest cause, caused due to autoimmune gastric atrophy, which causes loss of intrinsic factor, which is required for absorption of vitamin B12. So, and it is usually associated with other autoimmune conditions such as hypothyroidism. Second, dietary causes, example in vegans, and third, following total gastrectomy because of depletion of cobalamin stores, and fourth, any ileal disease such as resection of ileum or Crohn's disease, then malabsorption disorders such as celiac disease and tropical sprue. So hematological abnormalities now. Hematological abnormalities. First is macrocytic anemia, and MCV is usually more than 110. This is seen in both folate as well as B12 deficiency. Second, hypersegmented neutrophils. It is also seen in both folate deficiency and B12 deficiency. Third, serum B12 is low. Serum B12 is low. Fourth, homocysteine. It is a supplementary test where there is an indeterminate serum B12 level. Deficiency of cobalamin results in elevation of plasma total homocysteine. This is not specific to cobalamin deficiency, as concentration of plasma total homocysteine are also elevated in folate deficiency. So, first hematological abnormality is macrocytic anemia. And MCV is usually more than 110. Second is hypersegmented neutrophils. Second hematological abnormality of vitamin B12 deficiency is hypersegmented neutrophils. and both of these are seen in both folate and vitamin B12 deficiency. Now third, serum B12 is low. Fourth, homocysteine. Third, serum B12 is low. Fourth, homocysteine. Homocysteine is a supplementary test where there is an indeterminate serum B12 level. And homocysteine deficiency of cobalamin causes elevation of plasma total homocysteine. Deficiency of cobalamin causes elevation of plasma total homocysteine. Second, it is not specific to cobalamin deficiency. Second is that homocysteine is not specific to just cobalamin deficiency, as concentration of plasma total homocysteine are also elevated in folate deficiency. So these are the things in hematological abnormalities of B12 deficiency: macrocytic anemia and MCV more than 110, hypersegmented neutrophils, both are seen in both folate as well as B12 deficiency, serum B12 is low, and homocysteine. Homocysteine is a supplementary test where there is indeterminate serum B12 level. Uh, deficiency of cobalamin causes elevation of plasma total homocysteine, but this homocysteine plasma total homocysteine is not specific to cobalamin deficiency. It is also elevated in folate deficiency. We understood total gastrectomy, it causes depletion of cobalamin stores. Yes. Now the management. Now management of B12 deficiency is hydroxycobalamin intramuscularly. Hydrox hydroxycobalamin. So this is all about B12 deficiency. Let's just go through once again. B12 deficiency, it is found in vitamin B12 is found in meat, fish, and dairy products, not found in plants. It binds to the caseal intrinsic factor in the stomach, then this complex is absorbed in the terminal ileum. Clinical presentation symptoms are those of chronic anemia such as fatigue, dyspnea on exertion. Neurological symptoms may also be present such as peripheral paresthesia and disturbances of position and vibration sense. And if it is incorrected, if it is not corrected, then the patient may also develop subacute combined degeneration of spinal cord leading to permanent ataxia. Causes are pernicious anemia, which is the commonest cause. Uh, Causes are first pernicious anemia, which is the commonest cause due to autoimmune gastric atrophy. It causes loss of caseal intrinsic factor required for absorption of vitamin B12. It is usually associated with other autoimmune conditions such as hypothyroidism. Second is dietary habits. Example, vegans. Third, following total gastrectomy due to depletion of cobalamin stores. Fourth, any ileal disease such as resection of ileum or Crohn's disease. And fifth is malabsorption disorders such as celiac disease and tropical spree. Hematological abnormalities of B12 deficiency are uh, macrocytic hematological abnormalities of B12 deficiency are macrocytic anemia and MCV greater than 110, hypersegmented neutrophils, both of which are found in folate deficiency as well as vitamin B12 deficiency. And serum B12 is low, and homocysteine. Now, homocysteine levels are actually raised in cobalamin deficiency. So, homocysteine. Now, homocysteine levels, it is a supplementary test where there is indeterminate serum B12 level. Now, deficiency of cobalamin causes elevation of plasma total homocysteine, but it is not specific to cobalamin deficiency because plasma total homocysteine can also become elevated in folate deficiency. Management of vitamin B12 deficiency is done by hydroxycobalamin, which is given intramuscularly. Hydroxycobalamin given intramuscularly. Okay. So that is all about. But here one more thing is very important, that we have to compare vitamin B12 and folate deficiency. Vitamin B12 deficiency and first malabsorption, second conditions, third inadequate dietary intake. So comparison between vitamin B12 deficiency and folate deficiency. Comparison of the causes. So malabsorption, here pernicious anemia, folate deficiency, poor bioavailability. Medical conditions, inflammation of small intestine, just celiac disease, tropical sprue, and Crohn's disease. And another is gastric resection, gastric resection for obesity or cancer. Here, medical conditions would be inflammation of small intestine. They will be same as vitamin B12 deficiency. Now, inadequate dietary intake. Low intake of cobalamin rich foods. Here, low intake of folate rich foods. Vegetables. So this is the comparison between vitamin B12 deficiency and folate deficiency. Comparison of the causes between vitamin B12 deficiency and folate deficiency. Vitamin B12 deficiency is caused due to malabsorption uh, conditions such as pernicious anemia, where due to deficiency of Kessel's intrinsic factor or due to autoimmune condition, gastric atrophy, loss of intrinsic factor leading to malabsorption of vitamin B12. Here, folate deficiency is caused due to poor bioavailability. Now, second medical conditions would be same except the gastric resection or gastrectomy and vitamin B12 deficiency. Both are caused by inflammation of the small intestine, such as celiac disease, tropical sprue, and Crohn's disease. And another is here gastrectomy or resection of or gastric resection, for example, in obesity or cancer. Folate deficiency, only inflammation of small intestine, that is celiac disease, tropical sprue, and Crohn's disease. Inadequate dietary intake, here it is caused due to low intake of cobalamin rich foods, vitamin B12 uh, caused due to low intake of cobalamin rich foods. Folate deficiency is caused due to low intake of folate rich foods. So this is the comparison. So in one exam, one distinction that may help you choose between B12 and folate deficiency is the diet. Good food sources of folate include broccoli, Brussels sprouts, uh, asparagus, peas, basically vegetables. This, if the given scenario is a vegan, it is unlikely that he is suffering from folate deficiency. In that case, pick B12 deficiency. So fruits and vegetables. It's a kind of a trick to remember. Folate rich, beef and bacon, or vitamin B12 rich or cobalamin rich foods. Therefore, vegans not suffer from folate deficiency because it is actually these vegetables are rich. folate rich foods. So vegetables are folate rich foods such as broccoli, asparagus, peas, and Brussels sprouts. Brussels sprouts. So, fruits and vegetables, folate rich, beef, bacon, and meat, fish, and dairy products rich in vitamin B12. Hydroxycobalamin intramuscularly for vitamin B12 deficiency. Here, pernicious anemia, poor bioavailability causes inflammation of small intestine, celiac disease, tropical Crohn's disease, and another here is gastric resection, not in folate deficiency. It is caused due to low intake of cobalamin rich foods, caused due to low intake of folate rich foods. Okay, let's move further now. So, high MCV and low hemoglobin means macrocytic anemia. And we already studied that vitamin B12 deficiency causes macrocytic anemia. Macrocytic anemia will have high MCV and low hemoglobin. So these findings, together with a history of gastric resection where there is malabsorption of B12, can occur, and it is also having symptoms such as loss of proprioception and vibration sense, neurological symptoms. So they all point towards the diagnosis of vitamin B12 deficiency. Okay, let's move ahead. Now, a 75-year-old man living in a nursing home is taken to the hospital by his nurse. He has been suffering from long standing constipation and has been having difficulty in passing stools for the past 7 days. He appears mildly confused and agitated. He has a heart rate of 110, respiratory rate of 30. On rectal examination, fecal impaction is noted. So, single most appropriate management in this case. So, in this case, we have to study about fecal impaction. First, if constipation is not treated and it is left to manifest for a long period of time, it can result in the development of fecal impaction, and whose symptoms may be seen as dehydration, tachycardia, tachypnea, agitation, and confusion. So if there is constipation and it is not treated and it is just left like that to manifest for a long period of time, it can cause development of fecal impaction, and the symptoms can be dehydration, tachycardia, tachypnea, agitation, and confusion. Now, a person with fecal impaction may require emergency treatment on or hospitalization. For rapid action, phosphate enema is preferred. Phosphate enemas contain sodium acid phosphate and sodium phosphate. These phosphate enemas, they contain sodium acid phosphate and sodium phosphate. The osmotic activity of sodium acid phosphate increases the water content of the stool, so that rectal distension follows, and it is thought that this induces the defecation by stimulating the rectal motility. It has a very quick onset of action, which makes enemas very useful for when a rapid evacuation of a stony dull fecal impaction is required. So here first we will study about fecal impaction. Now basically we have to focus on the management of this condition. First step is to identify if the stools are hard or soft. Now, hard stools. For hard stools, consider using a high dose of an oral macrogol or osmotic laxative. For hard stools, consider using high dose of oral macrogol, oral macrogol, which is an osmotic laxative. Soft stools. Now, for soft stools or for hard stools, after a few days of treatment with macrogol, we have to consider starting or adding an oral stimulant laxative, Senna or Bisacodil. So, for soft stool or for hard stools, after few days of treatment with macrogol, here we have to consider starting or adding an oral stimulant laxative. We have to consider starting or adding an oral stimulant laxative, that is Senna or Bisacodil. For soft stools or for hard stools, after a few days of treatment with macrogol, we have to consider starting or adding an oral stimulant laxative such as senna or bisacodyl. So, if the response to oral laxatives is insufficient or not fast enough, then we have to use a suppository such as bisacodyl for softer stools, glycerol for hard stools. Remember, glycerol is a stool softener, and use a mini enema like docosate, which is a softener and stimulant. If the treatment is still inadequate, then we prescribe a sodium phosphate. Place this high up if the rectum is empty but the colon is full. Okay, so in both these cases, we were discussing oral laxatives, Senna or Bisacodyl here, and oral macrogol here, osmotic laxative. Now, if the response to oral laxatives is insufficient or not fast enough, then we will use a suppository. For suppository, Bisacodyl for soft stools and glycerol for hard stools. We have to remember that glycerol is a stool softener, or what we can do is use a mini enema like docosate. Docosate is a softener and stimulant. Now this docosate is a softener and stimulant. So use a mini enema like docosate, which is a softener and stimulant. Now, despite all this, if the treatment is still inadequate, then prescribe a sodium phosphate, and it is placed high up in high up if the rectum is empty, high up if rectum is empty, and colon is full. Now these phosphate enemas are well known to help with the disimpaction quickly, but they should be used as one of the last resorts. Example, if a patient has been admitted for fecal impaction We have tried all the laxatives above, but the patient continues to have impaction and discomfort, then one would start phosphate enema. Phosphate enemas can also be used if there is a need for rapid disimpaction. Example, if the patient is going for a procedure where bowels need to be empty, or if the patient is elderly having obvious abdominal discomfort and becoming agitated. Remember that once successfully disimpacted, it is imperative to start regular oral measure to prevent the recurrence of the problem. So, phosphate enema, these are last resort. When all other laxatives have failed, or they can be used for rapid disimpaction. Example, operation where bowel needs to be empty, or patient is elderly with obvious abdominal discomfort and agitated. So this is how we will deal with fecal impaction. Let's just quickly go through it once again. The first step is to identify if the stools are hardened or soft. If there are hard stools, then consider giving high dose of an oral macrogol, which is an osmotic laxative. Hard stools, then high dose of oral macrogol, which is an osmotic laxative. If soft stools or hard stools in which after a few days of treatment with oral macrogol has already been tried, then we can give an oral stimulant laxative such as senna or bisacodyl. So in case of soft stools or in case of hard stools where treatment with oral macrogol has already been tried, we can start oral stimulant laxative like senna or bisacodyl. Now, if the response to these oral laxatives is insufficient, so if we have already tried these oral laxatives and the response is insufficient, they have not helped, then we have to use a suppository. In case of soft stool, suppository is of bisacodyl. In case of hard stool, suppository is of glycerol, and glycerol is a stool softener. Second thing what we can do is using mini enema like docosate. Docosate is also a stool softener as well as a stimulant. So we can give two things if these oral laxatives have failed. First, using suppositories, example bisacodyl in soft stool and glycerol in hard stool. Glycerol is a stool softener, and using mini enema like docosate. Docosate is a stool softener as well as stimulant. Now, despite trying all the things, if there is no impact, if there is no effect, and still the problem persists, every other method has failed, then we can go further with the usage of enemas, phosphate enemas. So if the treatment is still inadequate, then we prescribe a sodium phosphate enema. If the treatment is still inadequate, then we prescribe a sodium phosphate enema which is placed high if the rectum is empty and colon is full. These phosphate enemas, are well known to help with the disimpaction. So well known to help in fecal impaction and help in disimpaction quickly, but they should be used only as the last resort. Example, if patient has been admitted, we have tried all the laxatives, but the problem is continuing, there is impaction, there is discomfort, then we can start phosphate enema. Phosphate enema can also be used for rapid disimpaction. For example, preparing a patient for a surgery or an operation or a procedure where bowels need to be empty, and or if the patient is elderly and there is obvious abdominal discomfort and the patient is agitated. But once disimpaction has occurred, we have to start with the regular oral measures to prevent recurrence of the problem. So this is all about fecal impaction. Uh, what another thing we have to consider here is that if constipation is not treated and is left to manifest for a long time, then it can result in development of fecal impaction. And this fecal impaction will have certain symptoms like dehydration, tachycardia, tachypnea, agitated, and confusion if severe. So a person with fecal impaction may require emergency treatment or hospitalization. So for rapid action, phosphate enemas are preferred. Phosphate enemas contain sodium acid phosphate and sodium phosphate. Phosphate enema contains sodium acid phosphate plus sodium phosphate, and they have rapid action. And the osmotic activity of this sodium phosphate increases the water content of the stool. So what they do is uh, osmotic activity increases the water content of stool and causes rectal distension, which induces defecation by stimulating rectal motility. Quick onset of action. So therefore these are useful for rapid evacuation of stony-dull fecal impact. Okay, so Phosphate enema would be required here in this patient who was agitated, heart rate was high, respiratory rate was high, fecal impaction was there. So we will give phosphate enema in this case. Other options could have been hard and based on hard and soft tool, like they could have been osmotic laxative, oral macrogol osmotic laxative, or oral stimulant laxatives like Senna and Bisacodil, or it could have been suppositories like Bisacodil and glycerol, or mini enemas like Docosate, or finally, if everything fails, phosphate enemas, sodium phosphate enema, sodium acid phosphate enemas. So now a 48-year-old female presents with tiredness. This is a new questionnaire. A 48-year-old female presents with tiredness and painless dysphagia. She complains of feeling of something stuck in her throat. A full blood count shows microcytic hypochromic anemia. On examination, glossitis is noted. An esophageal web is found at the post-cricoid region. What is the single most likely diagnosis here? Okay, so here we have to study about Plummer-Vinson syndrome. Plummer-Vinson syndrome. Now, Plummer-Vinson syndrome is a condition where iron deficiency is associated with post-cricoid esophageal web. The syndrome most often affects middle-aged women. Condition where iron deficiency is associated with post-cricoid esophageal web. It is a condition where iron deficiency is associated with post-cricoid esophageal web, and it mostly affects middle-aged women. Now, presentation. So, presentation would be painless, intermittent dysphagia, the presentation would be painless, intermittent dysphagia due to esophageal webs. Second, symptoms of iron deficiency, anemia. Now, management. Management would be iron supplements, and second, dilation of the webs. So Plummer-Vinson syndrome is a condition where there is iron deficiency and anemia, where there is iron deficiency uh, associated with the post-cricoid esophageal web. Iron deficiency plus post-cricoid esophageal web. This is Plummer-Vinson syndrome. It most commonly affects middle-aged women, and symptoms or presentation will be there will be painless intermittent dysphagia due to esophageal webs, and there will be symptoms of iron deficiency anemia. Management will be iron supplementation, and second, dilation of the esophageal webs, post-cricoid esophageal webs. So that is all about Plummer-Vinson syndrome. So here the female was having tiredness and painless dysphagia, and something stuck in her throat, and there was microcytic hypochromic anemia, that is iron deficiency anemia. Esophageal web was also found in the post-cricoid region, so that is Plummer-Vinson syndrome. It is a condition where iron deficiency is associated with post-cricoid esophageal web, and it most commonly affects middle-aged women. Presentation would be symptoms are painless intermittent dysphagia due to esophageal webs, and symptoms of iron deficiency anemia. Management is iron supplementation and dilation of the cricoid esophageal webs. So this is all about Plummer-Vinson syndrome. Let's move ahead. So when somebody or when someone presents with dysphagia, iron deficiency anemia, and glossitis, Plummer-Vinson syndrome is the answer. So another question here. A 21-year-old man has been having abdominal pain over the past 8 months. He complains of mucus in his stools on occasion. He has abdominal bloating on most days. The bloating and abdominal pain is worsened after a meal and relieved by defecation. He has no weight loss. Abdomen is soft and non-tender. So now we'll study about irritable bowel syndrome. But before we do that, let's take a break for a while, and I'll be back soon. So now we will study about irritable bowel syndrome. Consider irritable bowel syndrome if any of the three symptoms last for more than 6 months. First, abdominal pain or discomfort. Second, abdominal bloating. Third, change in bowel habits. First is abdominal pain or discomfort. Second is abdominal bloating. And third is change in bowel habits. Now, other features seen in irritable bowel syndrome would be other features are like abdominal pain relieved by defecation, change in the stool frequency or form, altered stool passage, that is straining, urgency, incomplete evacuation, symptoms aggravated by eating, and passage of mucus rectally. So, abdominal pain relieved by defecation, abdominal pain relieved by defecation, change in stool frequency or form, altered stool passage, straining, urgency, incomplete evacuation. So, change in stool frequency or form, then altered stool passage, that is straining, urgency, incomplete evacuation, then symptoms aggravated by eating, and passage of mucus rectally. So, these are other features. So, irritable bowel syndrome is considered when any of the three symptoms are lasting for more than 6 months, that is abdominal pain or discomfort, abdominal bloating, change in the bowel habits. Other features are abdominal pain relieving by defecation, change in the stool frequency or fall, altered stool habits or stool passage, such as straining, urgency, incomplete evacuation, symptoms aggravated by eating, and passage of mucus rectally. Now, there are no diagnostic tests for irritable bowel syndrome, but one should be aware considering performing other tests for other diseases with similar presentations. Examples: IgA tissue transglutaminase antibody for celiac disease. Then fecal calprotectin for inflammatory bowel disease. Then FIT sample for colon cancer and CA125 for ovarian cancer. There are no diagnostic tests of irritable bowel syndrome, but we have to consider performing certain other tests for other diseases with similar presentations. Similar presentation. And these tests are: first, IgA tissue transglutaminase antibody. IgA tissue transglutaminase antibody for celiac disease. Second, fecal calprotectin. Fecal calprotectin for inflammatory bowel disease. Keep in mind, this is inflammatory bowel disease, not syndrome. FIT sample. FIT sample is done for colon cancer. Generally after 50 years. CA125. Ovarian cancer. Women after 50 years. So there are no diagnostic tests for inflammatory bowel syndrome, but we have to consider certain tests which are carried out for other diseases with similar presentation, such as IgA tissue transglutaminase antibody for celiac disease, IgA tissue transglutaminase antibody for celiac disease, fecal calprotectin for inflammatory bowel disease, FIT sample for colon cancer, CA125 for ovarian cancer. CA125 is for ovarian cancer, IgA tissue transglutaminase antibody is for celiac disease, fecal calprotectin is for inflammatory bowel disease, FIT sample is for colon cancer. FIT sample is for colon cancer. CA125 ovarian cancer, fecal calprotectin inflammatory bowel disease, IgA tissue transglutaminase antibody for celiac disease. Okay. So now, based on the history, inflammatory bowel syndrome can be divided into constipation predominant, diarrhea predominant, and mixed. Based on history, inflammatory bowel syndrome is of three types. First, Constipation predominant. Second, diarrhea predominant. Mixed. So on the basis of the history, it is of three types: constipation predominant, diarrhea predominant, and mixed. Now we have to see the management part. Management includes low FODMAP diet. Now low FODMAP diet. FODMAP are short chain carbohydrates which are poorly absorbed in the small intestine. Second, antispasmodics such as mebeverine and peppermint oil. Third, laxatives such as subcolas husk for the constipation predominant type. Fourth, loperamide for the diarrhea predominant IBS. So first is low FODMAP diet. So FODMAP are short chain carbohydrates which are poorly absorbed in small intestine. Second, antispasmodics like mebeverine and peppermint oil. Mebeverine and antispasmodics like mebeverine and peppermint oil. Laxatives, third are laxatives. Example, spahula's husk. It is for constipation type IBS. Then loperamide for diarrhea type IBS. So this is the management part. First is low FODMAP diet. FODMAP are the short chain carbohydrates which are poorly absorbed in the small intestine. So we have to give a diet which is low in that. Second, antispasmodics such as mebeverine and peppermint oil for reducing the pain, obviously, spasmodic pain. And third, laxatives in case of constipation type IBS. In case of constipation predominant inflammatory bowel syndrome, we have to give laxatives like isabgola's husk. In case of uh, subgula's husk or laxatives in case of constipation type IBS, whereas loperamide in case of diarrhea type IBS. Loperamide in case of diarrhea type IBS. So this is about inflammatory bowel syndrome. Inflammatory bowel syndrome symptoms are worse during eating, relieved by defecation, passage of mucus. So another important thing okay, first let's go through this quickly. Irritable bowel syndrome. Uh, any of the three symptoms, any of these three following symptoms lasting for more than 6 months will point towards inflammatory bowel syndrome. First is abdominal pain or discomfort. Second, abdominal bloating, and third, change in the bowel habits. Now, other features are abdominal pain relieving on defecation. Other features are abdominal pain relieving on defecation, change in the stool frequency and form, altered stool passage such as urgency, straining, incomplete evacuation, symptoms aggravated by eating, and passage of mucus rectally. There are no diagnostic tests for inflammatory bowel syndrome, but there are certain tests which we have to consider for other diseases with similar presentation, such as IgA tissue transglutaminase antibody, IgA tissue transglutaminase antibody for celiac disease, CA125 for ovarian cancer, FIT sample for colon cancer, fecal calprotectin for inflammatory bowel disease. Now, based on the history, it is of three types: constipation predominant, diarrhea predominant, and mixed type. Management: we have to give low FODMAP diet. FODMAP are short chain carbohydrates which are poorly absorbed in small intestine. Second, antispasmodics like mebeverine and peppermint oil. Third, laxatives like isopgula's husk in case of constipation type IBS, and loperamide in case of diarrhea type IBS. Now, irritable bowel syndrome is a likely diagnosis here given the symptoms of abdominal pain and bloating, and symptoms that are worse during the eating. Symptoms are worse during the eating, and abdominal pain or symptoms. First, symptoms are worse during the time of eating. They are relieved by defecation. There is passage of mucus. These are also part of the diagnostic criteria. See, abdominal pain relieved by defecation, and change in stool frequency or form, altered stool passage, such as straining, urgency, incomplete evacuation, symptoms aggravated by eating, and passage of mucus rectally. So, all of them are pointing towards IBS only. Another important feature of IBS is a change in bowel habits, diarrhea or constipation. Although it was not mentioned here, but it is important. Now, irritable bowel syndrome has a number of overlapping clinical features with inflammatory bowel disease. Okay, this is sorry, we got confused there. This is fecal calprotectin for inflammatory bowel disease, and this is irritable bowel syndrome, not inflammatory bowel syndrome. Now, namely abdominal pain, diarrhea, increased stool frequency, and bloating. These are the overlapping clinical features between irritable bowel syndrome and inflammatory bowel disease. Abdominal pain, diarrhea, increased stool frequency, and bloating. In general, inflammatory bowel disease has worse symptoms. The diarrhea and abdominal pain is more severe. Ulcerative colitis tends to have bloody diarrhea. Crohn's disease tends to have diarrhea associated with weight loss or right iliac fossa pain or ileitis. So their irritable bowel syndrome has certain overlapping features with inflammatory bowel disease, and these features are abdominal pain, diarrhea, increase stool frequency, and bloating. Abdominal pain, diarrhea, increased stool frequency, and bloating. Inflammatory bowel disease has more severe or worse symptoms as compared to irritable bowel syndrome. In ulcerative colitis, there is bloody diarrhea. Ulcers are there, inflammation is there, bloody diarrhea in ulcerative colitis. In Crohn's disease, whereas in Crohn's disease, diarrhea is associated with weight loss and right iliac fossa pain. Diarrhea associated with weight loss and right iliac fossa pain, that is ileitis. There are no diagnostic tests for irritable bowel syndrome, but in a patient like above, it would be worth excluding other differentials such as inflammatory bowel disease and celiac disease. IgA transglutaminase antibody, IgA tissue transglutaminase antibody for celiac disease. We have to carry out in that case to rule out celiac disease, and tests that would usually be ordered here are fecal calprotectin for inflammatory bowel disease, and IgA tissue transglutaminase antibodies for celiac disease. Other two tests are FIT sample for colon cancer and CA125 for ovarian cancer. Okay, so let's move further. So a 35-year-old man presented to his GP with the complaint of heartburn. This first occurred 4 weeks ago when he noticed epigastric pain with acid reflux causing a sour taste in his mouth following a meal. At the time of presentation, he claimed that only discomfort that he experienced was tenderness and pain in his epigastric region. He complained of no altered bowel habits, sweating, dysphagia, or generalized weakness. There was no history of weight loss. He was otherwise fit well before this episode with no previous history of NSAIDs use or recent infections. A neighbor advised him to try a popular heartburn remedy, so he went to his local pharmacy, tried an over-the-counter heartburn medication, Gaviscon. This only improved his symptoms minimally. The patient's past medical history is significant for hypertension diagnosed 2 years ago, which is now well controlled with medication. He used to drink around 2 to 4 cups of coffee per day, which he claims he has now reduced to 1 cup per day. He has no history of smoking, only drinks socially. Following his consultation, the patient was subsequently further investigated for Helicobacter pylori infection, and the test returned with a positive result. He was started on triple therapy to eradicate his H. pylori infection, and his treatment regimen was successfully completed. He has now returned for a review, states that he is still suffering from heartburn and indigestion. What is the single most appropriate test to ensure successful eradication of H. pylori or Helicobacter pylori? So here we have to study about common antimicrobials, which is not just related with gastroenterology but even respiratory, neurological, genitourinary, obviously GIT, ENT, and others. So here we can study about that first. But in this case, okay, we'll come to dyspepsia and H. pylori testing. First, we'll go through the antimicrobials. So, common antimicrobials. So, first, respiratory. In respiratory, mild community acquired pneumonia, we will give amoxicillin. Moderate community acquired pneumonia, we will give amoxicillin plus clarithromycin. Now, severe community acquired pneumonia, we will give coamoxiclav plus clarithromycin. Now, hospital acquired pneumonia, in this we will give antibiotics according to microbiology and local hospital guided. In hospital acquired pneumonia, we'll give microbiology and local hospital guided antibiotics. Now, in pneumocystis zerovecii pneumonia, pneumocystis zerovecii, here we will give cotrimoxazole. In pneumocystis zerovecii pneumonia, we will give cotrimoxazole. Now, in tuberculosis, we will give 8 weeks of rifampicin, isoniazid, pyrazinamide, ethambutol followed by 16 weeks of rifampicin and isoniazid. Okay, I was mute the whole time. I didn't realize. So, we studied about tuberculosis, 8 weeks of rifampicin, isoniazid, pyrazinamide, and ethambutol, followed by 16 weeks of rifampicin and isoniazid. In aspiration pneumonia, we'll give amoxicillin plus metronidazole. Neurological, in out of hospital meningitis, we'll give benzyl penicillin. In meningococcus, pneumococcus, or Haemophilus influenza meningitis in hospital, we'll give ceftriaxone. In listeria meningitis, we'll give ceftriaxone plus ampicillin plus gentamicin. But we know that listeria is immune to cephalosporins, but still they are given for the empirical treatment before the diagnosis is confirmed. Now, meningitis prophylaxis. Meningitis prophylaxis, for this we'll give rifampicin or ciprofloxacin. It is more preferred. Rifampicin or ciprofloxacin. Ciprofloxacin is more preferred for meningitis prophylaxis. Now, cryptococcal meningitis. Cryptococcal meningitis, in this we will give amphotericin B. In cryptococcal meningitis, we'll give amphotericin B. Okay, now we'll come on to genitourinary. In genitourinary, lower uncomplicated UTI in non-pregnant lower uncomplicated UTI in non-pregnant women, we'll give trimethoprim or nitrofurantoin. Trimethoprim or nitrofurantoin. In Candida albicans, we'll give cotrimoxazole or fluconazole. Candida albicans, we'll give cotrimoxazole or fluconazole. In Trichomonas vaginalis, we'll give metronidazole. In Trichomonas vaginalis, we'll give metronidazole. Now, bacterial vaginosis. In bacterial vaginosis, we'll give again metronidazole. In cervicitis, in cervicitis, such as gonorrhea and chlamydia, we'll give ceftriaxone, stat, and azithromycin, stat. Now in syphilis, we'll give penicillin G, penicillin G. In genital herpes, in genital herpes, we'll give acyclovir. In genital herpes, we'll give yes, in NHS the spelling is different in the UK. So it can be acyclovir or acyclovir. Both are correct. Anyway, so in genital herpes we'll give acyclovir. Now coming to gastrointestinal. In Salmonella, Shigella, or Campylobacter. Here we'll give erythromycin, azithromycin, or ciprofloxacin according to guidelines. Now in Clostridium difficile, in Clostridium difficile, here we'll give oral vancomycin, which is the first line. In Clostridium difficile, we'll give oral vancomycin, which is the first line. In Helicobacter pylori, we'll give amoxicillin plus clarithromycin. Now in Helicobacter pylori, we'll give in Clostridium difficile, we'll give oral vancomycin, which is the first line. In Helicobacter pylori, we'll give amoxicillin plus clarithromycin. Now coming to ENT. In ENT, acute bacterial otitis media, here we'll give amoxicillin. In upper respiratory infections like pharyngitis, laryngitis, tonsillitis, here we'll give phenoxymethylpenicillin. Phenoxymethylpenicillin penicillin. Now certain other antimicrobials in cellulitis, we'll give fluclo- flucloxacillin. Flucloxacillin. In mastitis, same we'll give again flucloxacillin. In diabetic foot, we'll give again flucloxacillin. In osteomyelitis or septic arthritis, here we'll give again flucloxacillin with plus sodium fusidate. Sodium fusidate. Now scabies. In scabies, we'll give 5% permethrin. In scabies, we'll give 5% permethrin. Now toxoplasmosis. In toxoplasmosis, we'll give pyrimethamine plus sulfadiazine. Pyrimethamine plus sulfadiazine in toxoplasmosis. So these are some common antimicrobials which are used. Now we'll discuss about general management of dyspepsia. By the way, the answer for that question would be C13 urea breath test. Now we'll study about general management of dyspepsia and Helicobacter pylori testing. So this is what we'll study here. The general management for dyspepsia for patients less than 55 with no red flags. For patients less than 55 years with no red flags. First, try lifestyle modifications and antacids. If there is no improvement, then perform H. pylori antibody testing. If there is no improvement, then perform Helicobacter pylori antibody testing. Now, if serum antibody is positive for H. pylori, eradicate and review in 4 weeks. Or if it is negative, then prescribe PPI, proton pump inhibitors, or H2 blockers for 4 weeks and review. So if it is negative, prescribe PPIs or H2 blockers for 4 weeks and review. Now, after 4 weeks, if resolved, if the test was positive, and after 4 weeks, if it is resolved, no further action required. If symptoms still not resolved, then perform urea breath test. If urea breath test is positive, eradicate again. If urea breath test is negative, then do upper GI endoscopy. Now, if the H. pylori antibody testing was negative and we prescribed PPIs and H2 blockers for 4 weeks and reviewed, if symptoms resolved, then no action needed. But if symptoms do not resolve, then do upper GI endoscopy. So this is the whole management of dyspepsia for patients less than 55 years with no red flags. While we put in this diagram to use H. pylori antibody testing if no response to lifestyle modifications and antacids, but NICE recommends any locally validated test. NICE recommends any locally validated test for H. pylori, which includes the carbon 13 urea breath test, stool antigen test, or serum antibody testing. NICE recommends that if no response to lifestyle modification and antacids, then any locally validated, like carbon 13 urea breath test, stool antigen test, or serum antibody testing. They can be done. In practice, if the patient is taking proton pump inhibitors, remember to stop it 2 weeks prior to performing urea breath test or stool antigen test. Stop proton pump inhibitors 2 weeks prior to performing urea breath test or stool antigen test. So we have to, if the patient is taking proton pump inhibitors, we have to stop it at least 2 weeks before performing urea breath test and stool antigen test. The only one test which we need to remember for retesting for H. pylori is carbon 13 urea breath test. As NICE recommends, this is their this as there is still insufficient evidence to recommend stool antigen test as a test for eradication, and serological tests have no value in confirming successful eradication because antibodies persist long after successful eradication. So this is preferred. So here what we have to focus is general management of dyspepsia and H. pylori testing for patients less than 55 years with no red flags. So here, first try lifestyle modifications and antacids. If there is no improvement, then perform H. pylori antibody testing. But NICE recommends that if there is no response to lifestyle modification and antacids, there is no improvement, then we can even perform directly carbon 13 urea breath test or stool antigen test or serum antibody testing. But NICE prefers carbon 13 urea breath test more because for a stool antigen test there is no enough evidence, and serological test or serum antibody tests, these are not they have no value in confirming the eradication because antibodies can persist even after successful eradication. So for retesting performed by NICE, this is important because performed by NICE for retesting of H. pylori. Okay, so here we have to perform H. pylori testing, antibody testing. Now, if serum antibodies are positive for H. pylori, we have to eradicate it and review it in 4 weeks. Now, if the situation resolved, no further action is required. If the situation is not resolved, then we have to perform urea breath test, carbon 13 urea breath test. If it is positive, then we have to eradicate again. If it is negative, we have to perform upper GI endoscopy. Now, if H. pylori antibody testing is negative, then we have to prescribe proton pump inhibitors and H2 blockers for 4 weeks and review. If symptoms resolve, no further action is needed. If symptoms do not resolve, then directly we have to do upper GI endoscopy. NICE recommends that. So, although we here are suggesting H. pylori antibody testing if there is no response to lifestyle modifications and antacids, but NICE recommends any locally validated test for H. pylori, which include carbon 13 urea breath test, stool antigen test, and serum antibody testing. In practice, if the patient is taking proton pump inhibitors, then we have to remember to stop them 2 weeks, at least 2 weeks prior to carrying out these urea breath test or stool antigen test. The only one test which need to remember for retesting for H. pylori is carbon 13 urea breath test, because NICE recommends this test as there is insufficient evidence in case of stool antigen test for eradication, and serological tests also have no value in confirming the eradication, because antibodies can exist even after successful eradication. So, it is only necessary to check for the eradication of H. pylori in patients whose symptoms return. Here we perform that only. So it is only necessary to check for the eradication of H. pylori in patients whose symptoms return. In this case, patient was tested positive for H. pylori and started on triple therapy. His history shows that his compliance was good and he successfully finished the treatment. However, he still complains of indigestion. So the issue in this question is to choose a single best test which will confirm the eradication of H. pylori. We know that the answer is urea breath test, as this is the only test that NICE recommends post eradication. Carbon 13 urea breath test recommended by NICE post eradication. But there can be C14 urea breath test as well. According to the National Institute for Health and Care Excellence, the urea breath test is the only current valid method for detecting eradication for H. pylori infection. Now, urea can be labeled with two different carbon isotopes. It can be C13 or C14. The main difference between them is that C14 is radioactive, whereas the C13 is stable. C13 urea breath test is the recommended test to perform This is because it is non-radioactive isotope which can be used safely for repeated testing, and it is frequently required in clinical practice. So not C14 because it is radioactive in nature. Whereas C13, it is stable and hence recommended by NICE, that is National Institute for Health and Care Excellence. So it is non-radioactive, it is stable, it can be used repeatedly in clinical practice. Now, if the urea breath test is positive, then another attempt to eradicate Helicobacter pylori would be appropriate. It is important to remember these 2 points. Proton pump inhibitors must not be used 14 days prior to testing. So proton pump inhibitors must be stopped at least 2 weeks prior to performing urea breath test or stool antigen test. There must be a 28-day break after treatment with an antibiotic prior to testing. First is PPIs must be stopped at least 14 days before C13 urea breath test. Second is 28 days break after treatment with an antibiotic. So if the patient is taking an antibiotic, there must be a break of at least 28 days before carrying out the test. So 28 days break after treatment with an antibiotic prior to testing. So these two things are important to remember. Endoscopy is only required if Helicobacter pylori is completely eradicated as shown by urea breath testing to further investigate the cause of dyspepsia. Endoscopy is only required if Helicobacter pylori is completely eradicated as shown by urea breath testing to further investigate the cause of dyspepsia. So here we have to remember that carbon 13 urea breath test is the only valid test recommended by NICE for detection of eradication of Helicobacter pylori. So for post eradication, not C14 because it is radioactive, this is stable and hence recommended. Two things to remember are: first, PPIs must be stopped at least 14 days prior to carrying out carbon 13 urea breath test, and 28 days break should be there if the patient is taking an antibiotic. So 28 days break should be there after the treatment prior to testing. Endoscopy carried out to further investigate the case of dyspepsia, to investigate the cause of dyspepsia if Helicobacter pylori is eradicated. Okay, let's move further. So now, a 34-year-old man. In this question, we have a 34-year-old man with a long-standing symptoms of gastroesophageal reflux disease has an endoscopy which confirms Barrett's esophagus. What kind of histological change is seen in the mucosal cells lining the lower portion of the esophagus? So here we have to study about Barrett's esophagus. Now, Barrett's esophagus results from prolonged exposure of uh, Barrett's esophagus results from prolonged exposure of normal esophageal squamous epithelium to acid reflux seen in GERD. Mucosal inflammation and erosion occurs which lead to the replacement of the mucosa with metaplastic columnar epithelium. So esophagus, which is usually lined with squamous epithelium, it is replaced by columnar epithelium, that is there is metaplasia. So esophagus is now lined with columnar epithelium. Now we have to think of Barrett's esophagus and cervical ectropion the same way, because the columnar cells are replacing the squamous cells. The columns are coming. Okay, that is like a tip to remember. Columns are coming. Columnar cells replace the squamous cells. There is an increased risk of esophageal adenocarcinoma in patients with Barrett's esophagus. Therefore, these patients need to be monitored closely. So there is an increased risk of esophageal adenocarcinoma in patients with Barrett's esophagus. Therefore, these patients need to be monitored closely. Okay, so Barrett's esophagus results from prolonged exposure of normal esophageal squamous epithelium to the acid reflux in gastroesophageal reflux disease. Mucosal inflammation and erosion occurs, leading to replacement of the mucosa with metaplastic columnar epithelium. So normal esophageal squamous epithelium, due to the repeated exposure to acid reflux in GERD, due to mucosal inflammation and erosion, it is replaced. This squamous epithelium is replaced by columnar epithelium, uh, that is by metaplasia, or it is replaced by metaplastic columnar epithelium. And there is an increased risk of esophageal adenocarcinoma. There is an increased risk of esophageal adenocarcinoma in patients with Barrett's esophagus. So they need to be monitored closely. And so we have to think of Barrett's esophagus and cervical ectropion in the same way, because in both the cases the replacement occurs by columnar cells. Columnar cells are replacing the squamous cells, and the tip is columns are coming. So this is about Barrett's esophagus. Barrett's esophagus is a condition in which there is an abnormal metaplastic change where columnar epithelium replaces the normal stratified squamous epithelium in the lower portion of the esophagus. In the lower portion, or gastroesophageal junction, or GE junction. And this occurs in the presence of prolonged acid injury seen in patients suffering from GERD, that is gastroesophageal reflux disease. There is an increased risk of esophageal adenocarcinoma in patients with Barrett's esophagus. Squamous metaplasia is incorrect. There is columnar metaplasia. Squamous metaplasia is where the lining of the cells undergo benign non-cancerous changes to a squamous morphology. It is quite the opposite in Barrett's esophagus, as here stratified squamous epithelium is replaced by columnar epithelium. Therefore, it is columnar metaplasia. There is columnar metaplasia, not squamous metaplasia, because squamous may the lining of the cells would undergo benign non-cancerous change to a squamous morphology. There will not be metaplasia there. Metaplasia is there, but yes, to the same morphology. Here it will be columnar metaplasia. So again, Barrett's esophagus results from prolonged exposure of normal esophageal squamous epithelium or stratified squamous epithelium to acid reflux due to GERD or gastroesophageal reflux disease, and due to mucosal inflammation and erosion, it leads to replacement of the normal esophageal squamous epithelium by columnar epithelium by metaplasia, or it is replaced by metaplastic columnar epithelium. So there is columnar metaplasia which is happening. This is termed as Barrett's esophagus, and there is an increased risk of esophageal adenocarcinoma in patients with Barrett's esophagus, so they are monitored closely. So columnar epithelium replaces squamous epithelium, just like cervical ectropion. Same thing happens in Barrett's esophagus, and the tip is columns. The columns are coming. Let's so guys, let's wrap up here uh, for this session, and we'll continue from here in the next session. And till then, take care of yourself. See you.